When is it menopause? Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For me, that is Darkinjung country, and I'd like to also pay respect to elders past, present, and emerging. Now, a few things to let you know about this session. It is being recorded and it will be available for you to view in our vertical integration library in a few days' times. As attendees, we ask you to please mute yourself, but please feel free to unmute at any time and contribute. Today's session will be quite interactive, so we encourage you to pop anything in the chat or come on and speak up. And evaluation, we have Slido set up. I will also post the link and the QR code in the chat at the end so that if we shut down the session, you will still have access to Slido. Now I will hand it over to Dr. Nicole Avard from Next Practice at Arena.
Thanks, Sydney. Good morning, everyone. Thanks for joining us bright and early. I really appreciate your time and also appreciate you inviting me to share what is a passionate subject for me on menopause, particularly because I'm partly in it, but also because I see a lot of women and the impact that it's having on them. So let's jump in. As Sydney said, the slides are kind of short and sweet. I will really appreciate some interactions from you guys just in terms of either popping questions into the chat or answers into the chat, and let's just make it a light and easy, fun session. Okay, so just echoing Sydney's words, I'd also like to acknowledge country and the traditional owners of the land, which I am also on Darkinjung land, and pay my respects to elders past and present. And also just a call out to when I use the word woman in this talk, I'm talking to assigned female at birth. It's just easier for me to use the word woman or women. So let's go through what we're going to chat today. So first of all, I realised that I've already I'm a little bit dyslexic, so I've already made a typo on the slides, so don't worry about that. I was realising last night, late. What is menopause and how do you diagnose it? What are the common symptoms of menopause? Why does it matter? And that there's some impactful stats on why I feel really passionate about this subject that I'd like to share with you. How do you approach a consultation for a woman in her 40s, 50s or 60s that's potentially going through perimenopause and the menopause transition? Why is menopause so important in terms of preventative health? So a little bit to unpack there, and how do we investigate and help women manage that? An approach to treatment, and particularly all the landscape around MHT. So going to jump straight into handing it over to you guys if I can, and George is going to help me facilitate because I'm just kind of negotiating teams and chat and all that kind of thing. So can you help me with what you guys know as what menopause is?
Do we call it out or do we educate? Put stuff in the
Either's fine. Please feel free to unmute your mic and jump in, or if you feel more comfortable putting stuff into the chat, that would be super helpful too.
Sure. A cessation of menstruation for more than 12 months continuously.
Awesome. Well done. High achievers. Awesome. So that is correct. So menopause is actually, I've lost my, hang on a minute. I'm just going to stop sharing. I've lost it. Have you still got me here?
Yes. Yep. The screen's still on.
Yeah. It's just frozen for me. I'm just going to stop sharing for a little bit. Just give me, I might just have to jump. Oh, there we go. So correct, menopause is one day in the life of a woman, which is the day that is 12 months after the cessation of her last period. As we just said. So unless it is surgical menopause, which is where a woman has both her womb and her ovaries taken out through surgery, or iatrogenic, often of which is usually chemotherapy. So keeping in mind, although this is an obvious thing, that if you have a hysterectomy, you will still cycle through your regular hormonal cycle, and that's where it's a bit tricky to know what's going on in terms of menopause for the woman, because they're not sure of when their cycle is. Just getting a little delay on my click, so sorry about that. Having said that, there is a time leading into menopause of about 4 to 7, sometimes even up to 10 years, where we describe that as the perimenopausal period. So quick ovulation 101 or menstrual cycle 101. As we know, women has a cycle, and then FSH will rise in order to help estrogen thicken up or start to grow the lining of the womb. There is an LH surge, which happens with ovulation, and then progesterone is released, which makes the endometrium nice and plump in order to hopefully receive a baby. And if that doesn't happen, if an embryo doesn't implant, then the cycle starts and we go again. So what's happening in the perimenopausal period is there is an irregularity of ovulation, a bit like when at menarche, when you're a teenager. And therefore there is a significant hormonal fluctuation where estrogen is kind of going up and down and progesterone is generally on the downward decline. And that can cause a whole that hormonal fluctuation can cause a whole range of symptoms for women in that perimenopausal phase. And there's some that are more prevalent in the perimenopausal phase and some that are more prevalent in the postmenopausal phase, remembering that menopause is being just one day in the life of a woman. So, finally organise my clicks here. The only time in which blood tests are helpful for diagnosing menopause is if a woman has had a hysterectomy or an ablation. In that case, they're not sure when their cycle is doing, particularly with an ablation. They may have an irregular cycle or no cycle at all. And in that circumstance where a woman is not sure what her cycle is doing because of those two things, it can be helpful to check an FSH level to help the diagnosis of menopause, which is classified as 2 FSHs greater than 25, more than 6 weeks apart. It's the only real time it's helpful to do blood tests. Otherwise, it's pretty unhelpful because it's so fluctuant and fairly inaccurate. Okay, let's jump over to you again. There are 3 kind of symptoms that we're going to talk about. The first is physical, the next is psychological, and the third category is those that are often not spoken about, but are often extremely impactful for women. In Australia, the average age for menopause is 51. If a woman presents to you with amenorrhea for more than 6 months, definitely more than 12 months, aside excluding pregnancy, then it is definitely important to undertake a premature ovarian insufficiency investigative process. And there's some great resources out there, even on the AMS, so the Australian Menopause Society website, of a good pathway to explore for and undertake for premature ovarian insufficiency. If a woman is 40 to 45, then sometimes it's appropriate to undertake a POI investigation pathway, but most of the time that would be classified as early menopause. It's important that we don't just while menstrual cycles can change with stress, and it's not uncommon that women in this age group are experiencing a large amount of stress because they're often working, they often have young children or teenage children, and they're parenting up and parenting down, often to aging parents as well. So there's lots of spinning plates for women in this age group. It's important to just ensure that we're not just putting the period changes down to stress only, particularly if you're concerned about a premature ovarian insufficiency. The impact, most importantly, unless aside fertility, which most women in their early 40s would not be exploring, but some are, is particularly on bones and cardiovascular risk for premature ovarian insufficiency. So that's why we want to know about it. So, physical symptoms. Can you guys help me out here? What are the common physical symptoms of perimenopause and the menopause transition?
Hot flushes.
Well done. Hot flushes.
Night sweats.
Well done. Night sweats.
Prickly skin.
Oh, excellent. Yep. Formication, prickly skin, crawling on the skin. Good one.
Joint pain.
Yep. Excellent. Joint pain.
Mood changes.
Yep. So we'll chuck that into psychological and we'll dive into that a little bit more. But yep, well done. Mood changes.
Sleep disorder.
Yes, sleep disorder. So above and beyond the hot flushing, there is a change in circadian rhythm and restorative sleep patterns in the menopause that that is quite significant for women. So not only can they be woken with hot flushes and night sweats, but there is also a physiological change in the sleep architecture. Yep.
Hirsutism and male pattern balding.
Yeah, not put at the top of the list, but certainly can occur. Definitely hair loss is a big one, that's for sure.
Vaginal atrophy.
Yes. And what kind of symptoms would we put with vaginal atrophy? Yep, dyspareunia.
Dryness and itch and irritation.
Yep, dryness, itch and irritation. Yep.
Mm.
Awesome. You guys are all over it.
And bladder infections more frequently.
Yep, recurrent UTIs. Awesome. You guys have got it covered. So I think you've covered actually all of them. So I'm going to click through my recalcitrant clicker here. And is it slowing down on your screen too?
I've just got the title physical.
Yeah. All right. I seem to have lost my, seems to just go a bit. There we go. Changes in menstrual cycle. So that's one we didn't call out. So let's hand it back over to you. If a woman was presenting with heavy menstrual bleeding, A, how would you define that? And B, what investigations or what things would you be looking for in investigations?
We used to call it dysfunctional uterine bleeding.
Mm-hmm.
I can't remember what we call it now. So I'm too old.
So things to think about. So heavy menstrual bleeding, there used to be a kind of a term used. I think it was more than 70 mils, but it's a very research orientated term, and not many women are using cups and measuring exactly how much they're bleeding out. It's defined now really as being impactful on the women's daily life, with symptoms such as, concern for flooding and going out in public, bleeding through at night time, and having to change overnight, changing of sanitary products more than hourly, and the passing of clots. So pretty much if the woman is impacted by the heaviness of her cycle, then that would be the definition of heavy menstrual bleeding. Things to look out for there are endometriosis, if they've got a history of dysmenorrhea and dyspareunia, endometrial polyps, certainly fibroids, adenomyosis, and very, very rarely, but most importantly, if you're investigating postmenopausal bleeding, endometrial cancer. So always worthwhile if someone presenting with irregular PV bleeding to think about doing a pelvic ultrasound and definitely checking their iron. In my world, I like women's ferritin to be above 30. It's not a common occurrence, but I feel like women just generally feel better if their ferritin is above 30. Said that. Weight gain is another one. So estrogen is an important cofactor for insulin. So once women hit their 40s, there is a general decline in caloric need, and weight gain is common in the late 40s and into the early 50s. And I've got no evidence for this, but my general kind of practice or experience is that women often do the same thing through their early 40s. They may even be moving a little bit less because of their job, or they're running kids around in the car and they're very busy. They sometimes often drinking a little bit more, 1 or 2 glasses of wine at night to de-stress a couple times a week. And because of those subtle changes in movement and caloric intake, there is a slow kind of burn of weight gain through the kind of early 40s and into the later 40s. And once women are hitting 50, then it's a little bit harder to get off. And we'll talk about there's no amazing solution for postmenopausal weight gain, and I know semaglutide and Ozempic are trying to jump into that space, and we'll have a little chat about that towards the end. Dry skin, formication, hair loss, bloating, psychological. So we jumped onto that. there is an increased incidence of depression and anxiety in the perimenopausal transition and menopause. And for those that have had a past history of anxiety and depression, there is definitely an increased risk of recurrence at this time. And unfortunately, the highest suicide rates for women are in the 45 to 55 age group, which is really quite disturbing. There's also a high divorce rate for this age group. Irritability, rage, anxiety, palpitations, obviously needing to exclude other cardiac events. The brain fog is significant. So women will, oh shit, sorry about my language. The brain fog is significant. Women will say that, you know, if they're in whatever job that they're doing, they could competently feel like they could do their job very well, and then the brain fog impacts them, and they almost lose a sense of themselves and start to kind of have a little bit of self-doubt and lack of confidence, which is, again, we don't have an amazing solution for, but MHT can have an impact on that. But it's certainly definitely something to be asked and spoken about to see if we can get some support in the workplace for them if it is impactful. Vaginal dryness, my big kind of take home for anyone who's with a menopausal woman, and since the adjunct of self-collect for pap smears, please just look at the vulva. There are many vulval conditions that can happen in this age group that are not vaginal atrophy, such as lichen sclerosis and psoriasis and contact dermatitis. So my big kind of teaching take-home point is please look at vaginas, because it's important that we don't know, not missing something else. Urinary frequency, not so much stress incontinence, which still can happen at this age group, but certainly the menopause transition is associated with urinary frequency. Recurrent urinary tract infections, as we spoke about, because the estrogen is important for keeping the vaginal and urogenital tract kind of plump and well hydrated, and in order to prevent infections. Painful intercourse and low libido. The reason why I say those not spoken about is because women will usually present to me with the first two, the physical and the psychological symptoms, and the incidence of these symptoms is quite common. You know, at least 50% of women will have these symptoms, probably even more, and they're often not brought up unless they're asked about. I've got a number of women that are actually athletes trying to keep fit, riding bikes, doing sculling, those types of things, and the vaginal dryness is quite impactful when they're obviously, you know, sitting on their seats for their sport. Why does it matter? So it affects 100% of women. Most 20% of women will have no symptoms and manage the menopause transition quite well. 60% of women will have mild to moderate symptoms, and 20% of women will have severe symptoms. So you're probably looking on average at least, you know, kind of 50 to 60% that are having some element of moderate to severe symptoms at any point in time that needs to be help educated, empowered, and make accurate decisions on. So at the moment in Australia, that's estimated that there's about 1 million women going through the menopause transition at the moment. I'm currently undertaking a project where we're trying to improve education and awareness and support for women in the workplace around menopause. And the reason why we're doing that is because of the impacts we've just spoken about, the symptoms we've just spoken about, particularly the mood symptoms and the brain fog. There is an ABS graph where 25% of women are taking on less leadership roles or reducing their hours. So you can see there's a male and female graph, and at 45, the male graph just keeps going up, and the women's graph just drops down like that. Now, we don't know if that's completely menopause, but I guess we can infer that it's likely to have a role there. 40% of women are taking more sick leave as a result of the symptoms of menopause, and actually 10% are leaving the workforce. And this is at a time where, you know, they're often at their most productive and often at their most kind of empowered to move forward because the training's been done. They're, you know, have got a lot of scaffolding and foundation in their role, and the cost to business for these women leaving the workforce is massive. The recent report from Australian super funds reckons that it's costing Australia $112 billion in lost super for the impact that menopause is having on the workforce. So that's why it's important to ask about it and really kind of dive into it. So how do we dive into it? First of all, history taking. So let's jump over to you. What kind of questions would we ask for a consultation?
And feel free to write in the chat box if you don't want to unmute.
So obviously it depends on what they're presenting with, unpacking the symptom that they're presenting with, which may well be changes in the menstrual cycle. So understanding what their menstrual cycle is doing, how regular is it, how long do they bleed for, would you class them as having heavy menstrual bleeding? Is there any intermenstrual bleeding, and most importantly, is there any postcoital bleeding which requires an immediate pap smear and referral to gynecologist for further investigation? Spoke about that. This is just the symptoms we unpacked, right? Is there hot flushing? Is it occurring through the day? Is it waking them at night? If they're still getting their cycle regularly, are they getting a flare in any premenstrual symptoms, breast tenderness? It's common if people are migraine sufferers that during the perimenopausal phase, their migraines can actually increase. Painful periods, sleep disturbance. It's the common pattern that I see is that most women are exhausted, so they're getting off to sleep okay, but they're waking very frequently at night. So often waking every hour, every 2 to 3 hours, and sometimes having difficulty getting back to sleep. Changes in weight, dry skin and hair, bloating, and just a note here to take care with ovarian cancer. I know that's a little bit of a frightful one for us in general practice land, but obviously lots of things can cause bloating, but just to have it on your red flag list to whether a woman needs an pelvic ultrasound. Are they getting joint pain, and how is that impacting on their movement? Again, the psychological symptoms. So there is a excellent questionnaire called the MenOD that was spawned by Professor J.R. Ashi down in Monash University. That's an excellent questionnaire for helping discern if women have a recurrence of a previous depression or if it's actually menopause-related depression. So I know it's a busy time in a consultation, but certainly doing a DAS21 and a MenOD can be helpful for discerning what the impacts of menopause are having on their mood. Is there irritability and rage? There can be shame around women's and what they're experiencing at the moment, so they may not offer that up. So definitely asking those questions, same as emotional liability. And what is their impact on work? What are they doing, and are they finding that difficult at the moment? And obviously family and relationships. And then there's our social. So do they smoke? Are they drinking? What are they eating, and how much are they exercising? And we'll move on to the reasons for that soon. I'm going to flick through that because we've done that quite quickly in the interest of time. Just to call out on intimacy and pleasure. So it's often, again, can be difficult and awkward conversations, but I do find it really important in the context of low libido and painful intercourse, just to see where the woman is sitting in terms of the connection of their relationship with their partner, not just being about penetrative intercourse, but are they maintaining a level of intimacy and pleasure, because that can be quite crucial at this point in their life if there is relationship, kind of discourse. So back to you, preventative health. What kind of things do we want to know that the women are up to date with?
Cervical screening.
Thank you.
Good time for bone density.
Yep, so there's definitely Medicare criteria for how we ascertain or undertake and ascertain a BMD scan. So just helpful to call that out, that if women don't meet those Medicare criteria, then they'll have to pay for it. But yes, they're on them, and I've got a little slide on osteoporosis coming up.
And Kelly's also written mammograms.
Yep,
in the chat.
awesome. Yep, awesome. And then one more in the context.
Cardiovascular risk.
Yep. So as I've said there, perimenopause and the menopause is a gateway to an increase in chronic conditions. So it's important that we grab this opportunity to help women reduce their risk for cardiovascular events, osteoporosis, breast cancer, and ensure that their CST is up to date. Obviously, digging into their family history and their history of these things in terms of changing their risk. And I think you guys have nailed all of that. So in terms of, you're probably aware, but in terms of bone density, I find the Garvan fracture risk calculator really helpful, just in terms of ascertaining what a woman's risk is of having a hip fracture or any fracture and whether there is an indication for treatment. And in case you haven't seen it, the Heart Foundation have just released, a couple of months ago, released an excellent new cardiovascular risk assessment tool, and that's the link there, which is really important for ascertaining cardiovascular risk. Are you guys aware of that, or have you used it?
Yes, my patients that live in Battery Bay aren't very happy that they're higher risk than.
Oh no, yes, that's right. Yes, the postcode centile is yes, is a controversial one, isn't it? But I do like the new assessment and the things that they've and the fact that you can kind of elevate up or down according to ethnicity and a couple of other criteria is really helpful. Particularly social isolation and mental health, I think is a really good one. Just to also be aware that as well as the sleep disturbance, then it's important to ask women if they are snoring. And we're probably aware of the Stop Bang questionnaire, although it can present a little differently for women. Just a call out for contraception. I have had the occasional woman in her late 40s who thought she was in menopause and was actually pregnant. So does a woman need contraception? The answer is yes, she does, for 2 years after the last cycle if she's under 50, and 1 year after the last cycle if she's over 50. And it's can be a bit of an awkward conversation because often women are just winging it, but just to kind of call that out for them. So this is just a helpful slide for who's at risk for osteoporosis. You probably know a lot of these risk factors, but just calling it out so you can remember. I'm not going to read them out because they're all there. I find this graph most interesting. So you can, this graph here, I'm just going to change because my little, this graph here is helpful in sharing with women the decline in bone density once they hit menopause. So it's just a useful resource to have. Okay. Examination, what kind of things do we want to be looking for? Started you off there.
Again, it depends on their presenting symptoms, but you might want to do a breast examination, an abdo examination, and a vulval examination. Yep,
awesome. Nailed it. Well done. Breast examination, abdo examination, vulval examination. Well done. Cervical smear if applicable. So, as I said earlier in the talk, the diagnosis is purely a clinical diagnosis, except in those exceptional circumstances where women have lost track of their cycle. The FSH we spoke about, greater than 25, more than 6 weeks apart. Just to call out for checking TSH and iron studies if there is heavy menstrual bleeding. I have to say, in my 25 years of clinical experience, I've rarely seen a hypothyroidism present as menorrhagia, but it's always important to check. As we said, assessing cardiovascular risk through the lipids, fasting BSL, and if a woman has a history of PCOS, then considering whether you're doing an OGTT for them. Pelvic ultrasound, as we discussed, for intermenstrual bleeding or menorrhagia. And then how do we support the women? So as you can see, already to date, the consultation could take a reasonable amount of time, just getting through all of the kind of, particularly if there's a mental health involved. So often we'll need to do this over kind of a series of consultations in order to provide a really holistic approach for the woman. So patient education, women, there is a lot of information out there. Being 49, almost 49, my Facebook feed is full of menopausal options for me. Most of which are unvalidated in science. So I think it's hard for women to get accurate and find accurate information. The Australian Menopause Society has some excellent they're not particularly kind of branded and pretty, but the Australian Menopause Society has some excellent fact sheets on what is kind of valid and scientifically proven for menopause. So that's the link there. As I said, there is a conversation that I often start around reducing their risk for chronic disease through their lifestyle measures. And we'll jump into that a little bit later. And then there's usually a conversation around MHT. For those where MHT is contraindicated, and there aren't many contraindications, there are some options for non-hormonal therapies as well. So I'm not going to read the slide out. I think you guys are really well aware of kind of lifestyle interventions, and obviously there is a lot here into what to start to support women. I usually, my approach is usually just to ascertain all of the information and then just, you know, in terms of a motivational interviewing type of style, just see what the woman's capacity is to make a change. And sometimes they don't have any capacity to make a change. I usually find the sleep is the first place that I start, because I find that sleep drives everything else. If women are waking tired, then they're often not motivated enough to exercise, or they're too tired to exercise. They're flagging fatigue into the afternoon, and therefore might require sugar pickups in the afternoon, and be grabbing for more refined food choices because they're tired. And if they're loading that up with a bit of stress, then they're drinking alcohol in the evening to manage that. So just as a kind of practical tip, often I start with sleep and try and improve their sleep, because until women are feeling a bit more restorative with their sleep, it can be really difficult for them to make other changes. And the last thing I want to do is be setting them up for a cycle of failure. So just to call out to, I love our local pelvic floor physios. I think it's an excellent resource for women around pelvic floor education, and a whole range of things, particularly around sexual health and relational health, and their urinary tract. So pelvic floor physio referral, if the woman is open to it, is really a powerful thing. So, yep.
Sorry, I've got a few comments about any tips for increasing intimacy and pleasure short of giving up work, etc. And
short of giving up work.
Bring the partners in to help them understand the situation.
Pretty sure I've popped some resources in at the end of the talk. I think I've got a couple of books that women can reach out to. So I'll just pause on that, because I'm pretty sure I've popped them in at the end of the talk. But great question. So let's talk about MHT. So the landscape's changed there. So with the Women's Health Initiative, which I don't know when that was, maybe 15 years ago, that kind of blew what was called HRT, now we're calling MHT, menopause hormonal therapy, out of the water. And I've got a little slide that I'll just show you, which is a dodgy screenshot of my screen, of how it was kind of a bit misrepresented. So far and away, it is the most effective way to assist with vasomotor symptoms and general symptoms in the menopause, both perimenopause and postmenopausal. If it is started before the age of, so the hot tips on MHT is, if it is started before the age of 60, we now know that there is a reduction in cardiovascular risk. There is an improved all-cause mortality and a reduced fracture risk. The breast cancer risk depends on the age of the woman and her other underlying risk kind of assessment, but it's quoted at around 1 in 1,000 to 14 in 1,000 depending on the age. Now 1 in 1,000 is more around for your standard risk woman. in her 50s, where 14 in 1,000 isn't more the ageing population who may have a higher family risk. I'm not sure if you're aware of the iPrevent website, but it's an excellent website out of a Victorian organisation that helps women. It's very comprehensive, and it's a great way for women to ascertain exactly what their breast cancer risk is, so that they can bring that to you and put that in the context of how that changes with MHT. Keeping in mind that the population risk at the moment for breast cancer is about 1 in 8, and I think that's now dropped to 1 in 7. There is definitely an increased risk of VTE, so thromboembolic disease, but it's low at 2 in 1,000, and it really depends on the delivery. And there was a recent study out of the Nordics, I think it was a couple of months ago, that showed that there was an increased risk, potentially increased risk of dementia. But that study needed to be taken with a little bit of care, because they used an older style form of MHT that we frequently don't use at the moment. And also there was a bit of kind of chicken and egg debate around the dementia risk was associated with women that had had more severe MHT symptoms, and was it that the menopausal symptoms, and was it that the menopause was a precursor for dementia versus MHT actually being an impactful event in dementia risk. We know that the pathogenesis of dementia is very multifactorial, so I think the jury's still out on that for the moment, and more studies need to be done. So sorry for the quality of this, and I'm not going to go through it, but it's just a bit of a dodgy screenshot from my computer of the Women's Health Initiative and the things that they got right and the things that were misreported. And I'll leave you to kind of ponder that, in your own time. So it's just a helpful kind of retro analysis of the study, keeping in mind that the most things was that they only used one type of MHT that we frequently don't use now, and it was generally an older population that they studied, and hence why some of the kind of stats were skewed. I find this slide really, really helpful. So this is the one I often bring up for explaining the breast cancer risk associated with MHT in women aged 50 to 59. So this line here is kind of average population. You can see that if you exercise for more than 2.5 hours a week, while your breast cancer risk actually goes down. Unfortunately, being overweight or obese actually increases your risk of breast cancer the most significantly, even more than what smoking does. Drinking alcohol also does. CCE is combined equine estrogen. So using estrogen alone actually reduces your breast cancer risk, and using CCE and MPA, medroxyprogesterone acetate, increases your breast cancer risk ever so slightly, but that is reduced by the change in progesterone that we're using at the moment. And I'll talk a bit more about that later, compared to the general population. So this is a slide that I use quite frequently in helping women understand their breast cancer risk in terms of where MHT sits, particularly if they're smoking, drinking, and not exercising, which again, we can help them with. Sorry for the lady who looks a bit like a vampire up in the top corner of this one. This was a bit dodgy screenshot from a webinar I was doing with the Menopause Society. So you've lost some of the graph at the end, but again, a really useful slide that I use for explaining risk of MHT to women between 50 to 59. Just a quick overview, black is estrogen only, the white bar is estrogen and progesterone. On my screen, if you're sitting to the left, then the risks are increased. If you're sitting to the right, then there's actual benefits. So you can see that there's benefits in multiple areas here: fractures, overall mortality, coronary heart disease, and the biggest, the breast cancer risk sits here, the VTE risk here, and the biggest risk is increasing risk of cholecystitis. But the numbers are still low. You're looking at 6 per 1,000 women episodes per every 5 years. So they're not massive numbers. The contraindications to MHT are actually quite minimal. So undiagnosed vaginal bleeding, active cardiovascular disease, you need to take care if someone is a high cardiovascular risk, for example, has hyperlipidemia or smoking, and you probably want to do it in conjunction with their cardiologist or a cardiology review, but it's not a contraindication if they are high cardiovascular risk. It's just that we would prefer to deliver the MHT transdermally. Obviously, an active or past history of hormonal sensitive cancer, such as breast or ovarian cancer. If they have a history of a previous VTE or a family history of VTE, then it's important to liaise with a haematologist around what is the safety for MHT there. It depends on what the family history is and what the context was, i.e. if it was provoked or unprovoked. So anyone who has a history of VTE, definitely check in with a haematologist in terms of whether they feel it's appropriate for them to use MHT, and intolerance or patient preference to any of the ingredients. So how do we deliver MHT? So pretty much there's tablets, patches, gels, pessaries, and all options are on the table. It really depends mostly on patient preference and also on cost, but also a little bit on risk. As I said, there is the lower risk is for generally delivering MHT transdermally, so either through a patch or a gel, except for micronized progesterone, which is a newer body identical progesterone. That's also lower risk than your classic medroxyprogesterone acetates. We deliver MHT cyclically if the woman is still having a cycle. That's where you give estrogen continuously and progesterone for the last 14 days of the cycle. It will induce a withdrawal bleed, and it's usually how it's delivered until 12 months after the last cycle. It's a little tricky when women are perimenopausal and they might be bleeding every 3 or 6 months, and then you say to them, I'm going to give you MHT if you would like, and it's going to induce a regular bleed. Often that's not an attractive option for them, but the flip side is that if you give them continuous estrogen and progesterone, then you might induce a really irregular bleeding pattern that they're not particularly happy about as well. Just to call out, and the next slide will show you that progesterone must be given in adequate doses if they're using estrogen, just to protect women's endometrial lining from endometrial cancer. I'm not going to go through all of these, but this is pretty much how the presentations present in options in Australia. Tablets, gels, and your progesterone options. MPA and norasterone are older style progesterones. I can never pronounce these correctly. Oh, go back. Oh, sorry. I've just got to go back. Oh no, now I've gone forward too much. Just going to see if I could go back.
I'll try and just hit the back arrow. That might work as well.
Oh, there we go. Thank you. So the newer progesterones out are dydrogesterone and drospiridone, and micronized progesterone is generally my favorite because I find that a little bit more calming on the nervous system and a little bit better for sleep. Certainly your LARCs, particularly Marinas, are an option as a progesterone option. I don't tend to use a lot of Implanon in this age group. And I don't actually know if the guidelines what the guidelines say about that. The reason why I flicked through that is that this is the most accurate kind of information on what to prescribe and how to prescribe it. So the AMS which I have pretty much open on my desktop all the time because I forget the brands and which one is which, have a very comprehensive guide on which brand has what estradiol and which brand has what progesterone. And there is a little bit of an art around starting and changing and trialing, which we probably don't have time for today, but just pop your eyes on this and have a look at kind of what's around. This is just a call out for how much progesterone is enough for endometrial protection in terms of the estrogen dose. The most important thing to flag here is that for perimenopausal women, if you're using micronized progesterone as an option, it's actually 2 tablets a day for the last 14 days of the cycle, depending, or always on the estrogen dose as opposed to 1, which is not particularly cost effective. So just to kind of let the woman know that is the recommended dose, and just the impact of cost there. And you can see the other equivalent doses for endometrial protection there. If a woman has a contraindication, then what's our options? There's really good evidence for CBT and mindfulness-based stress reduction programs for sleep. Hypnotherapy also has good options for sleep and actually vasomotor flushing, although access and cost may be an issue. You can use an SSRI or an SNRI, such as fluoxetine or venlafaxine, whatever, you know what I mean, Effexor, but not fluoxetine with tamoxifen, because there is a significant interaction where that will reduce the effect of tamoxifen. Other drugs that are often reached for is clonidine and gabapentin, not frequently because of the side effect profile for those two, but it is an option if women are particularly disturbed by vasomotor symptoms. And there are newer medications coming out soon, medications that are particularly working on the hypothalamus in temperature regulation, peptides to help control hot flushing for women that have contraindications to MHT. This is just a really useful slide on the effect of lifestyle interventions and MHT on vasomotor symptoms. So you can see an SSRI sits here, but most effective intervention was far and away estradiol. And the bit on intimacy. So these are just some really useful resources that women can read on pleasure and intimacy, and just kind of starting conversations around sex, not necessarily need to be penetrative, and how to explore that with your partner. There's a study that which is a little bit controversial probably, where they did a study of women, and they popped them into a chair, I think it was, and were monitoring if they were orgasming or not, and they put them in front of erotica, and the physiological markers were showing that 50% of women were orgasming, but their brains were actually not registering that they were orgasming. So the reason why I bring that up is that there, even though it's kind of sounds a bit flippant, there is a big lot of evidence for mindfulness, particularly for women, improving sexual kind of outcomes and sexual experiences because of, busy brains. So topical estrogens for vaginal dryness will certainly help with those symptoms if dyspareunia is an issue. As I said, the pelvic floor physios are amazing in this space, particularly around intimacy, touch and pleasure. Pleasure toys and lubricants, to explore, and kind of if they're okay speaking to their partners about pleasure toys being their friends, not their foe, in order to improve intimacy and connection. And as I said, the study on mindfulness. It's a bit controversial whether to use topical estrogen for breast cancer survivors. The literature is still a little bit unclear, and there's two sides of the story. Topical estrogen, the systemic absorption is actually really quite low, and there is a side even of oncologists that believe the systemic absorption is so low that it is safe to use in breast cancer survivors. But there is also another side to say, well, even though it's low, it's still there, and we don't know how much impact that has. And we'll probably never get great clarity around that, because no one's really going to do a study that says, here, take topical estrogen and see if your breast cancer recurs. But just to kind of reassure that the systemic absorption of topical estradiol into the vagina is actually really quite low. A little call out to Ozempic. So obviously, I just want to morally call out that obviously the preference is to keep Ozempic for type 2 diabetes and not jump on the bandwagon of weight loss in the menopausal woman. But the recent studies head-to-head with, I can't remember what, I can never say the drug names, that one, versus semaglutide, showed that it's actually a dose of 2.4 milligrams of Ozempic that is most effective for weight loss. That is not available in Australia at the moment. It may well be coming. And the impact on weight was, I think, 11% weight loss over 12 months. And then there was a 4% weight gain when Ozempic was stopped. So that's kind of the stats around Ozempic. I don't think I'll jump into cases because it's 8:20. So let's just open to questions. And if you've got any questions or comments or anything like that, because the cases are pretty self-explanatory from what we've discussed. But maybe if you've got specific questions around prescribing or anything like that, just let me know.
Chrissy.
Yeah, hi. Just around the point you made about the difficulty in prescribing cyclical estrogen to a woman who's having irregular periods, that's a common problem that I face. What do you tend to do? Do you tend to use the cyclical for 12 months and then change back to continuous?
I do, yeah. So I tend to use the cyclical for 12 months and yes, exactly what you said, change to continuous. And I tend to say to the woman, look, I'm not quite sure what your period's going to do, but at some point in time, we will change to continuous and see what happens.
And if you go straight to continuous, worst case scenario is they just get unpredictable bleeding, is that right?
Yes, yeah.
Yeah, okay. Thanks.
That's okay.
Do you have any comments about tibolone?
Oh yeah, I didn't put tibolone on there, but it is on the great to be used. The issue with tibolone is that you need to stop it after 60 because there's an increased risk of stroke. So definitely an option to be used. Again, in patient preference, if a woman wants to take a continuous option as a tablet, then that's totally fine.
Just earlier, Gordo made the comment about androfem.
Yes. Yeah. I've used androfem a little bit. The guidelines would say that testosterone technically should only be used for hyposexual desire disorder, so low libido and difficulty engaging with sex. And so, just excuse the phone in the background, sorry. So technically that's what's only to be used for. There are anecdotal studies around using it for mood and energy, but I tend not to. It's mainly for sexual dysfunction that testosterone is meant to be prescribed for as a transdermal gel.
And just a question from Ian, can you use continuous HRT in the perimenopause, just like we do with contraception, and then just have a 5-day break when the bleeding starts?
Generally not. You would, well, it depends on what their cycle's doing. If the definition of perimenopause is a change in menstrual cycle of more than 7 days for 2 consecutive cycles. So if they've still got a cycle, then the recommendation would be to still cycle it.
I know I've read and been advised in the past that if they're under 50 and they've got those perimenopausal symptoms, you can just go a low dose pill as well.
That is true, yeah. So that is an option as well, yeah. Yeah. Particularly if they need contraception, right?
Exactly.
Yeah.
And Ian did want to ask why, if you could elaborate at all.
Not to use continuous and take the 5-day break.
Ian, do you want to turn your mic on?
He might not be able to unmute. I'm not sure what he means there.
Because of the irregularity in the bleeding pattern, it could just be too disturbing. The other thing to call out is that Slindia, the new progesterone-only pill, is an option as well in that age group if they require contraception, and it might give them some management of their menopausal symptoms, contraception, and little or regular cycle. So that's another option to use.
And it's not approved yet to combine that with a bit of estrogen at all? Is that in the pipeline?
Yeah, I don't know the answer to that, but I don't think it is. Yeah, I think it's just, in that kind of, it's probably off label for MHT use, I suspect, as well. But if you need the contraception piece.
Any other final questions? We've got, Chris has put a few nice little links in there, like some therapeutic guideline tables as well, so it's always a good resource.
Thanks, Chris.
And you mentioned the AMS as well. That's a great. I've got that handout on my table as we speak. So
yeah,
that one.
I mean, even though I do it regularly, I've always got to flick to that. The AMS prescribing guidelines. Jean Hales Institute also has some accurate information for women.
And there's always little shortages of at the moment there's a Climara.
There's a Climara short, yeah.
Yeah, so that's really tricky. There's always one of them that's unavailable. Any tips of the trade there?
Pull up the my desktop and just try and match accordingly. So basically, when you look at that reference, the prescribing reference from the AMS, it categorizes them into low dose, medium dose, and high dose. So it's just trying to find an option in the same category that a woman feels like she wants to swap to, whether it's transdermal or oral.
Great. Any other further questions? No, that was amazing, Nicole. So it's a very
it's a whirlwind tour, so I didn't think I'd take that long, but I realised as I'm talking, there's a lot of information actually. So.
Yeah, and as you said, you don't have to do it in one consultation, and usually there are some little blood tests you might need to do, whether it's checking their thyroid or their iron, or depending on what's going on, whether they do need hormonal treatment. But yes, it can be done over quite a few consultations, and usually double appointments are required. But no, you've definitely given us a great outline, and not being afraid to ask those questions about intimacy as well, as patients won't necessarily bring them up. So no, that's fabulous. So thank you very much, Nicole. And,
thank you. Thanks for the opportunity.
Yeah, no worries.
Thanks for bearing with me with my team's kind of PowerPoint virgin experience.
All good. And everyone, don't